Hey everybody, welcome to our second lecture on the female reproductive system. Today we're going to start out with a topic called oogenesis, which is the production of gametes. So we're making female sex cells here. And oogenesis starts in the fetal ovary. We're going to have cells called oogonia. They're going to reproduce by mitosis to make lots and lots. We're talking millions of these oogonia. Notice that they're diploid cells, and they are found in the fetal ovary. So, fetal ovary, lots of diploid stem cells called oogonia. Each oogonium is going to replicate its DNA, and it's going to turn into a primary oocyte. The primary oocyte is going to be part of a primordial follicle. So here's a primordial follicle right here, surrounded by a layer of simple squamous supporting cells. And in that fetal ovary, each primary oocyte, which is inside a primordial follicle, is going to start doing meiosis, which is our two-stage cell division where we make haploid cells. And the primary oocyte starts doing meiosis, but it gets blocked. And it stays blocked unless it gets the correct hormonal signal, which is only going to happen during a menstrual cycle. Okay, if a primary oocyte gets the right signal, and the right signal is called LH, it stands for luteinizing hormone. If a primary oocyte gets that signal of LH at roughly the midpoint, like day 14 of a menstrual cycle, then and only then will a primary oocyte continue to divide. All right, obviously in the previous slides, we were in the ovary of the fetus, right? Well, now, if we're talking about menstrual cycles, we are beyond puberty here, okay? Now we're talking about a female who has menstrual cycles. And in the middle of every menstrual cycle, one primary oocyte will respond to this hormonal signal, LH, which stands for luteinizing hormone, and the primary oocyte is going to undergo meiosis 1, in which it divides. When it divides, the diploid primary oocyte turns into two haploid cells. There is a haploid cell called a first polar body. That first polar body might divide again, or it might just die. If it does divide, it is just the two daughter cells are just going to divide. The secondary oocyte is the cell that is going to be ovulated, meaning it is going to be released from a rupturing Graafian follicle and then swept into the neighboring fallopian tube. Now, the most likely thing to happen to an ovulated secondary oocyte is it'll die. It'll only keep going with its development if it is fertilized by a sperm, if a sperm cell binds to its receptors on its surface. If the sperm cell binds to it, then and only then will the secondary oocyte undergo the second division of meiosis. And in response to that division, we get a haploid cell called a second polar body. That cell is simply going to die. And then we get another haploid cell called the ovum. This is the female gamete right here. And here's what we got to realize. The ovum is weird in that it has its own nucleus, its own haploid nucleus, but it's also by now got the nucleus of the sperm cell in it. And these two guys are about to fuse. And because they're about to fuse, they're given the name pronuclei. Each is called a pronucleus. Now, once the pronuclei fuse together, the ovum has then turned into a zygote, which is the first cell of the eventual new human being. However, do realize the most likely thing to happen to a zygote is that it will die within mom's fallopian tubes, or just tube, singular. Okay, so that is oogenesis. That is how we're making female gametes. Notice a couple things here. Notice that we started in the ovary, right? We started in the ovary. And a lot of the work happened in the ovary. We made millions of primary oocytes in the ovary. Most of them die before puberty. And the ones that last till puberty Only one keeps going per menstrual cycle. So if you do the math here, not a lot of primary oocytes are going to undergo this first division and make secondary oocytes. I mean, if it's one primary oocyte per menstrual cycle that divides, I mean, how many menstrual cycles is a woman going to have between puberty and menopause, taking away any cycles that just happen to be irregular, taking away any time when she is pregnant or lactating? We're talking maybe 400 secondary oocytes are going to be made. And then secondary oocytes only go on to become ova, which are the gametes, if fertilization occurs. So contrast that with the guy. The guy makes trillions of sperm cells, the male gamete. A female is only going to make, who knows how many ova. Maybe she'll make like 10. Maybe she'll make less. Maybe she'll make more. But nowhere near the amount that the male is going to make. Okay, topic 1, oogenesis, done. Let's move on to the ovarian cycle, which is the set of events happening in the ovary every 28 days. And we're then going to talk about the uterine cycle, and we can kind of like put it all together in our heads as we talk about the entire menstrual cycle. So we're going to assume a 28-day cycle, but obviously it doesn't have to be 28 days. It could be shorter, it could be longer, it varies. We're going to call the first 2 weeks the follicular phase and the second 2 weeks the luteal phase. And day 14, which marks the transition between these two phases, is going to be ovulation day. Okay, so follicular phase part 1, days 1 through 7. The hypothalamus is releasing gonadotropin-releasing hormone, causing the anterior pituitary to release FSH and LH. Meanwhile, follicles are growing in the ovaries. Growing follicles are secreting estrogen. Estrogen actually tells the anterior pituitary to start to hold on to FSH and LH. Estrogen also is going to prepare the uterus for pregnancy. In other words, it's going to cause that stratum basalis, which is the superficial layer of the endometrium, to get thicker as the body assumes, hey, I'm going to ovulate and then I'm going to get pregnant. And by the way, notice we got a couple primordial follicles here. We got a nice primary follicle right here. All right, so take a look at our graph here. We got our LH and our FSH. We got our estrogens down here. Notice that during the first 7 days or so, FSH and LH start to go up a little bit at first, and they're kind of leveling off. Estrogen has come down from the previous cycle, and it's going to gradually start to climb here. Okay, in days 7 through 14, follicles are still developing. We got a secondary follicle here, note that. Estrogen levels are rising. FSH and LH levels are now starting to fall. If I go back to my graph, look at how FSH levels are coming down here. LH is still kind of like plateauing here. And as estrogen levels rise, FSH and LH go down. And eventually, we're going to end up with just one mature follicle. Let's take a look at it. One mature Graafian follicle at the end of this follicular phase. So like by day 14, we've got one mature Graafian follicle, which is going to start to bulge from the wall of the ovary. Okay, on day 14, right before the ovulatory event, a couple things have to happen. Number one, we got a Graafian follicle now, and the Graafian follicle is making just a ton of estrogen. And estrogen levels are going to reach this threshold value, and as a result, the anterior pituitary is going to release the stored FSH and LH. There is going to be a surge in plasma LH, and that surge in plasma LH, which, let me jump real quick. Look at the graph. Look at the plasma LH surge at day 14. Look at just this super sharp spike here. And that surge in plasma LH causes the primary oocyte to complete meiosis 1. So remember, the primary oocyte divides, gives us a secondary oocyte and a first polar body. The secondary oocyte is then going to be ovulated. The LH causes the Graafian follicle to start to squeeze and squeeze some more, and then it bursts. And it releases the oocyte into the surrounding peritoneal cavity, where it gets swept into the fallopian tube. Then the LH also causes the leftover cells of the Graafian follicle to be transformed into a brand new structure, which is called the corpus luteum. All right, if we look at this picture here, we do see a primordial follicle becoming a primary, still a primary pre-antral follicle, then it's a secondary, then it's a Graafian follicle. Remember, this takes multiple cycles to occur, and by the time we get here, this guy is pumping out a lot of estrogen, and he's starting to bulge from the ovarian wall. And when the estrogen levels reach a peak, a threshold value, the estrogen tells the anterior pituitary to release a surge of LH. The surge of LH causes the primary oocyte to divide, becoming a secondary oocyte in the first polar body. Then it causes the cells around the follicle to start to really squeeze and contract. And you know, there's fluid in this antrum here. And when we squeeze a fluid, you can kind of see what's going to happen. There is going to be a weak point at the wall, and it's going to pop. It is going to burst. The wall of the ovary will actually bleed a little bit. The follicle bursts. The oocyte, which is a secondary oocyte by now, as well as its surrounding supporting cells, they are going to be released into the peritoneal cavity, only to be swept into the fallopian tube, where they might or might not meet a sperm cell. All right, notice that much of the Graafian follicle is still in the ovary post-ovulation, and LH converts that Graafian follicle remainder into this yellow structure here called the corpus luteum. Corpus means body, luteum simply means yellow. All right, we saw that surge. That surge is so important on day 14. Now, post-ovulation, we are in the luteal phase. Days 14 to 24 is where we're going to start. Remember, we're assuming just a basic 28-day cycle. And the big job of the corpus luteum is going to be to make progesterone. Progesterone. Sterone means, the own part means like steroid. So it's a steroid for pregnancy. So the body is assuming that it is pregnant now. So it's secreting this hormone called progesterone, and progesterone levels are now going to go up. Progesterone causes the uterine lining to become more vascular, more glandular, causes it to be even thicker than before. And of course, when we say uterine lining, we're specifically talking about the stratum functionalis of the endometrium. Meanwhile, progesterone is going to decrease the release of LH and FSH from the anterior pituitary. Think about it. If the body is saying, I'm pregnant, then we want to stop follicle development and stop ovulation. It doesn't make sense to waste follicles or to ovulate if the body is pregnant. So that's why we're shutting down LH and FSH. So now, as we see progesterone levels are going up during this luteal phase, LH and FSH levels are coming down. All right, now we're going to run through two scenarios, pregnant and not pregnant. If pregnancy does not occur, when progesterone is going up and up and up, that makes LH go down and down and down. And when LH reaches a low value, like a low threshold, the corpus luteum actually starts to die. The corpus luteum needs LH in order to stay alive. And so when LH levels reach a critical low, the corpus luteum starts to die. When the corpus luteum dies, it turns into a mass of scar tissue called a corpus albicans. And then without a corpus luteum, progesterone levels are going to plummet. Once progesterone levels have fallen, Then LH and FSH are going to start to be released from the pituitary again. The uterine lining is going to be shed, and a whole nother cycle is going to begin. And uterine lining shedding, of course, is menstruation. All right, what if pregnancy does occur? Well, if pregnancy does occur, we don't want the corpus luteum to die. And luckily, the developing placenta makes a hormone called HCG, which stands for human chorionic gonadotropin. HCG is going to bind to the corpus luteum, keeping it alive for a couple months until the placenta is able to take over its job. There's a corpus luteum of pregnancy right there, and this is an ovary, and this is the corpus luteum of pregnancy here. And with the corpus luteum sticking around, progesterone levels stay up, the uterine lining stays intact, which allows pregnancy to continue. And because we're pregnant, we don't let any follicles develop or ovulate in the meantime. All right, we talked about pregnancy tests and old school pregnancy tests in labs, so I'm not going to cover that on the video here. But I do want to jump into the uterine cycle, which we've kind of hinted at already. So we know that ovarian hormones, estrogen and progesterone, are changing during the cycle. We saw how estrogen levels were going up in the follicular phase, how progesterone levels went up during the luteal phase. And those estrogen levels, the rising and falling of them, impacts the uterus. And we actually talk about the events in the uterus in terms of 3 phases. And again, we're saying it's 28 days. And again, our days here are not absolute. Of course, individuals certainly vary. The 3 phases are days 1 through 5, the menstrual phase, days 6 to 14, the proliferative phase, and days 14 to 28, the secretory phase. So in the menstrual phase, days 1 through 5, plasma progesterone levels have gone down because the corpus luteum died. And without that high level of progesterone, the stratum functionalis is now no longer getting the signal to stay put. And the stratum functionalis is going to be shed. Blood and tissue is going to slough out of the vagina. And of course, that is the act of menstruation. Days 6 through 14 are the proliferative phase. And during this phase, ovarian levels of estrogen are increasing. So estrogen levels are rising. The stratum functionalis is going to grow and get thicker. This is because the body is again saying, all right, well, this cycle, we're going to get pregnant. And we can totally see the functionalis getting thicker here on these days. Notice the basalis doesn't really change, stays pretty constant. Also, the rising levels of estrogen are going to affect the mucus in the cervix. They're actually going to decrease its viscosity. In other words, they're going to make it get thinner because that's going to provide an easier route for sperm to swim through. All right, so that's days 6 through 14. Of course, remember on day 14, we have ovulation day. And then post-ovulation, we are in the uterus's secretory phase. And now progesterone levels are rising because we got a corpus luteum. The stratum functionalis is now getting even thicker and thicker. Look at the growth and elaboration of the blood vessels and glands, all in preparation for pregnancy. And meanwhile, now cervical mucus is going to get thicker because now the body is assuming, hey, we're pregnant. So it doesn't want to let anything through the cervical canal that could be harmful to the developing embryo. So the viscosity of the mucus is going to increase. It is going to thicken. And of course, assuming pregnancy does not happen, eventually progesterone levels are going to fall, and then the stratum functionalis is going to be sloughed away, and we're back at the beginning of the menstrual phase. All right, couple more things to do. Some extra uterine effects of ovarian hormones. So estrogen and progesterone do a bunch of things. In the pubescent female, estrogen promotes bone lengthening, so bone growth, as well as epiphyseal plate closure, Remember, the epiphyseal plate was the growth plate where long bones are growing. So estrogen makes the long bones grow pretty quickly, but it also shuts down the growth plate pretty quickly, so growth will stop. Estrogen also inhibits bone resorption, which is the breakdown of matrix, the bone matrix, so the collagen and calcium hydroxide, and the cells that normally do that are osteoclasts. So estrogen inhibits osteoclasts. This is why a menopausal woman would start to be at greater and greater risk of osteoporosis. Plus, estrogen promotes hydration of the skin, female pattern of fat deposit and hair growth, retention of sodium in water, raising the good HDL cholesterol, and lowering the bad LDL cholesterol. Meanwhile, progesterone raises body temp and promotes urination. Okay, some important terms and events. Of course, puberty is that period of life in which the reproductive organs become adult size and functional. The first menstrual period is known as menarche. Menses refers to the normal flow of blood and tissue during menstruation. An abnormal cessation of menstruation is amenorrhea. Menopause is the normal cessation of menstrual function that happens in a person's fifth or sixth decade, so in their 40s or their 50s. And finally, I got a pair of internal genitalia structures here. We can see the ovary, uterus. And obviously, can you figure out that one of them is premenopausal, one is postmenopausal? Can you tell which is which? I know you can. And let's end with a couple follicles just to admire. So we got some Graafian follicles, some primordial follicles as well. I don't know why I have follicles at the end of my slideshow, but I do. So let's take a look at them and appreciate them for a moment here. And with that, we are done female repro. Yes. And with that, we're actually done all of our videos for AP2. So if you watched every single one, if you watched every minute of every video for lecture, let me know. I will just, applaud you, shake your hand, congratulate you, and think that that's fantastic. Okay, see you later. Bye-bye.